This is a presentation for the knee, imaging of the knee. The commonest injuries in the knee region are those involving ligaments and meniscal injuries, fracture patella, fracture tibial plateau, and osteochondral fracture. The possible to miss lesions are the fracture tibial spine, the osteochondral fractures, fracture tibial plateau, second fracture, and what's called as the deep notch sign. Deep notch sign. Now, indirect sign for trauma is the swelling, and the swelling is due to effusion in the suprapatellar bursa, and here we have something wrong there with the patella, and consider in these cases tear of the ACL, collaterals, or meniscus. That means that you should search for other soft tissue injuries. The principle of fluid level is due to serum and lipohemoarthrosis, fat and blood. Fractures at the tibial plateau may be split fracture like this, or the breast fracture like this, or comminuted like that one. So here it's hardly seen, but if you look this area, this is something wrong in the outline, and here there is some depression with sclerosis, and here there is a definite split like that one. The value of MRI will show the brain edema, the bone edema, and will show the suspected fracture line along the tibial plateau, like that one, and this edema, which is seen as bright T2 signal. So we should search, is there a fracture? How much it is depressed? Are there associated injuries in the soft tissues, ligaments and menisci? And this is a list to search for: the medial collateral ligament, lateral collateral ligament, anterior cruciate, posterior cruciate, and the lateral meniscus. Here we have a fracture, and we have indefinition of the collateral ligaments, and there is the breast fracture, split fracture at the tibial plateau, and here there is interruption of the collaterals. So the MRI can show the whole thing, both soft tissues and bony. In this one we have a fracture of the tibial plateau, and you have here in the MRI the same, and that one is showing with bone edema, and this one appear to be abnormal, and this is the retracted part. That means that there is ACL partially. Some of the fibers are there, and some of the fibers are retracted, and here is the bone edema with the fracture tibial plateau. Fractures at the femur may be transverse, may be Y-shaped, reaching to the articular surface, may be reaching to the intercondylar notch or knot, may be involving the condyle posteriorly, or the appearances like that. If there is a fracture involving the distal femur and the proximal tibia, this is called floating knee. The deep notch sign is that one. It is this area where we find some depression along the femoral condyle, mainly the lateral femoral condyle, and this is usually accompanied with an ACL tear. So this is the deep notch sign, usually accompanied by lateral femoral condylar, usually involve the lateral femoral condyle and accompanied by ACL tear. Here we have what's called as kissing contusions, this area and that area. Kissing contusions are usually involving lateral femoral condyle and lateral tibial plateau, and usually the related meniscus is involved in a tear, like this one. There is torn meniscus and there is torn ACL. Second fracture is the elliptical vertical 3 by 10 millimeter fracture, separate fragment, about 4 millimeter distal to the plateau, best seen in AP. This is second fracture, and this means an ACL tear, and this is a mechanism. To fracture this, you should tear this one in diverting the axis, I mean changing the axis of the femur. To fracture this one, you should tear this one. So second fracture is usually associated with an ACL tear. Second fracture is sometimes involved with medial collateral avulsion. As we see here, there is some avulsion of the medial collateral ligament here. There is avulsion in this area. And as we see, we can find other associated injuries in the anterior tibial spine, or avulsion of the posterior cruciate ligament, or osteochondral fracture. The intercondylar eminence could be undisplaced with avulsion, could be avulsed, could be completely detached, and maybe detached and inverted upside down. Inverted upside down. Here is the undisplaced one, and here is another one showing separate fragment from the tibial plateau, and here is the fracture line. Osteochondral fracture, usually associated with avulsion of the posterior cruciate ligament, and here is the line of separation. Avulsion of the PCL, again here the PCL is avulsed at its origin, and this is a separate fragment. Avulsion of the tip of the fibula, this is called the crescent sign, and that means that the lateral collateral ligament is interrupted. Lateral collateral ligament is interrupted. The patella may be dislocated laterally, either fixed or can come again, transit. And this is evidence of transit lateral dislocation of the patella. Usually we have the medial retinaculum interrupted in transit dislocation. Maybe we have spontaneous resolution of the medial retinaculum and of the patella going back. The transit type dislocation of the patella is the most common. Of course, you can find kissing contusions. You can find large joint effusion. You will have the tear of the medial retinaculum, and you may have chondral or osteochondral injury. So in lateral dislocation of the patella, we have the transit type. This is the most common, and this is the mechanism, interruption of the medial retinaculum. So in the MRI, we will have the effusion, the torn medial retinaculum, the displaced patella, the kissing contusions, and maybe osteochondral lesions. Fracture of the patella may be transverse, vertical, stellate, displaced, comminuted, and avulsed superior margin, but take care that we have another type of patellar lesions called bipartite, which we have a corticated margin. This is congenital. Dislocation of the patella, here is evident that you get the interruption of the medial retinacula, the kissing contusions, here and there, and the joint effusion with separate fragment sometime, avulsed fragment. Here is the osteochondral fracture. Tears of the quadriceps and infrapatellar tendons will result in elevation of the patella. The patella will be shifted up. This occurs in chronic renal failure, diabetes, elderly, obesity, gout, and hyperpara. It will weakens the infrapatellar tendons, resulting in upward displacement of the patella. Anterolateral dislocation of the proximal tibiofibular joint. This fibula should be here. It can be dislocated outward like that. This is the normal and this is the abnormal. Anterolateral is pushed anteriorly and laterally from its attachment. Menisci. This is the appearance of the sky or the bow tie or the triangular appearance, and this is the cut within the body of the meniscus. This is the lateral meniscus, sharply defined, normal. This is the medial meniscus, sharply defined, normal. This is a cruciate ligament, posterior cruciate and anterior cruciate, and this is the patellar retinacula, this one and that one, and these are the types of tear in the menisci, grade 1 within the meniscus, and this is not considered a true tear. It's called mucoid degeneration. And the grade 2 we have the intersubstance tear, grade 3 with vacuolation, and the grade 3 also we can get the complete reach to the other side. It could be horizontal and could be vertical, so vertical and horizontal tear. In degeneration it might be like this small or larger or reaching to the surface, and these are the types of degeneration. It may be small like grade 1 tear or grade 1 degeneration, and this larger area of degeneration within the meniscus, and this one is larger area within the meniscus with fraying. That means it starts to break. Here is a horizontal tear, horizontal tear, horizontal tear. Here is a vertical tear, vertical tear. And is the radial tear is that one with the separation of one surface. It's a vertical tear of the free edge. Here, vertical tear of the free edge means this area, and thus we get the meniscus as a ghost. No meniscus seen, it's a ghost meniscus. And flap tear should be has one horizontal and one transverse, so this one and that one, and it's common in the medial meniscus. Two components, horizontal and vertical, horizontal and vertical and horizontal. This one is the horizontal tear and this one is the vertical tear. The bucket handle of the free edge will result in either decreased height of the meniscus, the height is small than expected, or the posterior part is displaced underneath the posterior cruciate, giving the double posterior cruciate sign. So we have decreased height, free piece like this. This is a free piece, and this is a small size, free piece, double sign of the posterior cruciate, and here we get the flattened or the small sized meniscus. All of these are signs of bucket handle tear of the free edge. So we'll repeat again: small size, three piece, double outline or double PCL sign, and small meniscus. That means that there is tear of the free edge. Of course, the sagittal will show the small size and the double PCL, while the coronal will show the medial displacement of the fragment. Now here we can apply what we have been learned: the coronal showing the piece, separate piece, the small size, the double outline, double PCL sign, double PCL sign. That means these are examples of bucket handle or radial tear. This is a flipped meniscus. That means it is removed from its side and then turned back like a U-shaped, and thus you can find two menisci at the same time in the sagittal. This appearance with constriction. It's no longer triangular. It's a flipped meniscus. Meniscocapsular separation, you will find this fluid at the junction between the meniscus and the surrounding capsule. Meniscocapsular separation, meniscocapsular separation, meniscocapsular separation. Many examples here and there. Discoid meniscus, that means you can get complete meniscus in many of the coronal cuts. It is a dysplastic meniscus, 50% of more coverage of the tibial plateau. The meniscal body segment is seen in 3 or more sagittal images. Here it is. This one, that one, and that one. The discoid meniscus is seen as continuous low intensity in more than 3 cuts in the sagittal plane. Meniscal cyst is something related to the meniscus and is full of T2 hyperintense fluid. The common site is the anterior horn of lateral meniscus and posterior horn of medial meniscus. A cyst is seen extending here from a meniscal tear. This is a meniscal tear and this is a cyst extending from it. This meniscus is divided into 2 with a tear in between, and this is a cyst continuous with the tear. Meniscal cyst, ACL injury, complete injury. Non-visualization of the ACL with a fuzzy appearance, cloudy edema, and hemorrhage. This is ACL injury. And here we have the ACL injury with kissing bruises. Signs outside the ACL are the bone contusions, the anterior translocation of the patella is shifted up, uncovered meniscus sign, avulsion fracture of the tibial insertion of the ACL injury, the presence of a second fracture, the presence of PCL buckling, the presence of PCL line sign. So these are the signs of ACL injury, either outside the ACL. Either you see the injury itself, or you see any of this: bone contusion, anterior translocation of the tibia, uncovered meniscus sign, avulsion fracture of the tibial insertion, the presence of a second fracture, or PCL buckling. Now here we have the anterior. This is the normal. It should be in line, and here there is anterior translocation of the tibia. Anterior translocation of the tibia. Anterior translocation of the tibia with uncovered meniscus sign. The meniscus is not covered. This is the PCL line sign. This is normal. It should touch here. The PCL. This is the normal, and this is abnormal. It should touch here. Here is touching. Here is not touching. This is positive. Partial ACL tear with focal angulation and increased T2 signal, or the single bundle sign. Either you find a single bundle sign like this, that means the other part of the ACL is retracted. That means that not the whole thickness of the ACL is involved. Partly it forms one line like this, and partly is retracted like this. Here there is partial ACL tear. There is single bundle sign with edema around. Chronic ACL tear. We have empty notch sign, fragmented. This is the one. This is a normal. This is the normal. You don't have it here. Absent bone edema. Fragmented ACL contusion will be seen, but in chronic ACL tear, of course, edema would subside, and the ACL itself will not be seen as a band inside the notch. As that's why they call it empty notch sign. The ACL may be degenerated, and we have an intraligamental cyst. Intraligamental cyst. The PCL may be avulsed if there is something involving the tibial insertion, like here, this one, with the retracted bone fragment and bone marrow edema appearing as T1 hypo intense. It is usually not involved because it's strong, and the meniscus femoral ligament connects the posterior horn of the lateral meniscus to the medial femoral condyle. The menisco-femoral ligaments are supporting. Ligament of Humphrey anterior to the PCL, ligament of Risberg posterior to the PCL. But if there is bone lesion, bone fracture, avulsion, it will involving the tibial insertion. This is the famous or commonest appearance of the PCL torn in fractures. of course is associated with bone edema at the site of the avulsion. Partial PCL tear, here it is, edema of the ligament, partial interruption of the ligament. The collateral ligaments, this is the normal, this is the abnormal, and here we find some edema around, slight thickening of the medial collateral, separation from the underlying cortices, should be coapted here and there. So the presence of fluid separating this band away from the cortex is denoting separation, and this separation is partial tear. A complete tear will be seen as interruption, and the ligament is folded up with surrounding edema. Chondromalacia patella, that means it's the bone is ulcerating. That's why you get this wavy appearance. The cartilage is lost, this layer is lost. Reactive bone changes, can be some sclerosis, and finally osteoarthritic changes. This is chondromalacia patella. We can find osteochondral pits, whether here or there, or this area. This again suggests the presence of chondromalacia patella. Chondromalacia patella is characterized by absence of the cartilage. This is the cartilage. Here it is not seen, and the bone itself is irregular, serrated, with reactive sclerosis of the patella, and sometimes we will find joint effusion, bone edema, and finally osteoarthritic changes. Loose bodies like that one, osteochondromatosis like this. So it could be synovial osteochondromatosis, as in this case, or it could be some fragments due to osteoarthritis. Lipoma arborescens is this front of fatty tissue projecting into the effusion. It's called lipoma arborescens. Here it is, these fronts projections inside the joint effusion. In hypertrophic synovial masses with hemosiderin-laden macrophages, that means pigmented velonodular synovitis, it will appear low intensity in MRI, and it is not inside the joint, it is related to the joint, as you said before, and of course it is formed of masses laden with hemosiderin-laden macrophages. The key point is the presence of bone erosions or cystic changes on the opposing surfaces of both bones, forming a joint on either side. You will find some cysts here and some cysts here, and soft tissue surrounding in the plane, and then in the MRI you will find this appearance, the marked low intensity due to hemosiderin macrophages laden cells and associated bone erosions. This is the typical appearance of osteochondritis, osteochondritis dissecans, not yet separated, line of cleavage, and well separated. Here, the bone marrow contusion is appearing as bright signal in T2 weighted images, stare for example, and low intensity in T1 weighted images. This is the appearance of the serpiginous pattern of bone infarcts, and bone infarcts could be due to Caisson disease, or those diving and suddenly getting out from water may result in nitrogen vacuoles within the bone, causing bone infarcts, within the vessels, causing bone infarcts like this. So bone infarction is a marrow process characterized by sclerosis of a serpiginous appearance. This represents that the vessels supplying this area were in spasm or occluded. Bone infarction. Here we can see the abnormal T2 hyperintensity of the infrapatellar tendon with the bone contusion of the inferior margin of the patella. This is patellar tendinitis. And here we find bone edema of the anterior tibial tuberosity, and this is the Osgood-Schlatter disease in acute stage. Of course, this one show the disappearance of the cartilage here, the relative narrowing of the joint, the marginal osteophytes, the loose bodies, the osteophytes and loose bodies, and this is the typical appearance of osteoarthritis, usually with effusion. Thank you.